So, a tale of viral keratitis with masquerading fungal infection. A long way to reach the happy ending. A 72-year-old male patient who is a farmer by occupation came with chief complaints of redness and defective vision in the left eye since 1 month. He had no history of trauma or past use of any topical or native medications. So on slit lamp examination, 4 mm central stromal haze, iris clumps on the back of the endothelium with 1 mm streak hypopyon was noted. There was gross reduction in corneal sensations, patent syringing, chaotic scrapings, and gram stain was negative. So a provisional diagnosis of viral stromal keratitis was made. Topical steroids in tapering doses, cycloprogix and oral acyclovir in twice daily dose was given. Improvement on follow-up visits was seen over a span of 3 months, quite surprisingly. So on the 4th month of follow-up, 4 mm central epithelial defect was seen with overlying 4 mm pigmented dry-looking infiltrate and 3 mm hypopyon. He again gave no recent history of trauma. So chaotic scraping showed fungal filaments. Culture sensitivity was positive for the metaceous fungi. So that's why we started with topical natamycin, oral ketoconazole, along with oral acyclovir. AC wash with intracameral voriconazole, vanco, and imipenem was given. Intrastromal vosal was also planned. Still, there was no clinical and symptomatic improvement on subsequent follow-ups. So B-scan revealed moderate vitreous echoes in the anterior and mid-vitreous cavity. So intracameral, intravitreal, intrastromal voriconazole were given after 2 weeks. Still, there was persistence of 4 mm central epithelial defect with overlying 4 mm pigmented dry-looking infiltrate and 2 mm hypopyon. So lastly, we planned an AMG overlay for the persistent epithelial defect, which led to complete healing of the infiltrate along with adjuvant topical and oral medications. The patient showed improvement in vision to 6 by 24 by Snellen's chart. So he was continued on oral acyclovir prophylactically for 6 more months. As we can see, the B-scan was also normal. So why this case? Two schools of thoughts. A case of fungal keratitis, which on presentation with 4 mm stromal haze and 1 mm hypopyon with grossly reduced corneal sensations, was misdiagnosed as viral keratitis. The patient was started on topical steroids and oral acyclovir. Although there was initial improvement, there was worsening of the clinical picture later, probably due to residual nidus of fungal infection which may have been present, which aggregated on use of topical steroids over a long period of time. So this led to persistent epithelial defect, fungal infiltrate, and hypopyon. So let's also not forget that he's a farmer by occupation. Or this might be a case of viral stromal keratitis which responded on management with topical steroids and oral acyclovir. This was superimposed with fungal infection on subsequent follow-ups, maybe because of past history of trauma which the patient is not giving us. Hence, the patient responded to topical or oral and intracameral and intrastromal antifungal medications along with AMG overlay for persistent epithelial defect. Oral acyclovir was continued in follow-up visits due to past history of stromal keratitis for the patient. So is this a case of viral keratitis with masquerading fungal infection, or is this a case of fungal keratitis with masquerading viral infection? So which case scenario do you agree with? Is this that a course correction has been done, or we were right from the first thing?
We have to treat both.
Thank you, Dr. Sowmya. Yeah, like initial when the patient presented, was there an epithelial defect?
No.
So I think your second hypothesis, I feel that's more likely that it was viral keratitis, stromal endothelitis or keratitis to begin with. The patient was a farmer, there was some trauma, and then there's a superimposed fungal infection, because to see a fungal keratitis with no epithelial defect is absolutely very, very rare. I mean, I haven't seen yet in my 15 years of practice.
Like if hypopyon is there and there is epithelial defect, it could be HSV, NSK. But if there is hypopyon and there is no epithelial defect, unlikely that it is
Yes.
virus.
Very unlikely to be
It's
fungal.
fungal, so
Yes, yes.
likely.